Welcome to this video where we will explore the neonatal hyperbilirubinemia, a condition commonly seen in newborns. By the end of this video, the viewer will be able to understand the basic epidemiology of neonatal jaundice, explain the pathophysiology of neonatal hyperbilirubinemia, recognize the clinical presentation for a neonate with jaundice, conduct a diagnostic evaluation for neonatal jaundice, and describe the management of neonatal jaundice. Hyperbilirubinemia is an elevated serum bilirubin concentration that is greater than the 95th percentile for the age, causing jaundice, that is, or yellow discoloration of skin, sclera, and mucous membrane, and requires treatment with phototherapy. Bilirubin is a yellow pigment produced from the breakdown of RBC. It's the normal byproduct of hemoglobin metabolism. However, in newborn, excess bilirubin can accumulate in the blood, leading to hyperbilirubinemia. Neonatal jaundice is the most frequently encountered medical condition in the second week of life and a common cause of readmission to the hospital after birth. Approximately 60% of term and 80% of preterm newborn develop clinical jaundice in the first week after the birth. Neonatal jaundice is usually a mild, transient, and self-limiting condition known as physiological jaundice. However, this should be distinguished from the more severe pathologic jaundice. Physiological jaundice is a common condition in newborn, appearing around the second or third day of life and resolving within the 2 weeks. However, if bilirubin level rises excessively or too rapidly, it can lead to pathological hyperbilirubinemia, which requires medical attention. Newborn are particularly prone to hyperbilirubinemia due to several factors like increased bilirubin production. Newborn have a higher RBC turnover rate due to a shorter lifespan of fetal red blood cell. This leads to increased hemolysis, producing large amount of unconjugated bilirubin, which is fat soluble and not easily excreted. Another one is immature liver. Unconjugated bilirubin must be processed in the liver to become water soluble. However, in newborn, the liver enzyme UDP glucuronide transferase is immature, slowing this conjugation process. As a result, unconjugated bilirubin accumulates in the blood. Likewise, poor breastfeeding can lead to a dehydration and inadequate stooling. As a result, there is a decreased clearance of bilirubin via the stool. In addition to this, infection, metabolic disorder, and genetic factors can affect the liver function and play a vital role in neonatal jaundice. Now, let us talk about pathophysiology of neonatal hyperbilirubinemia. Hyperbilirubinemia in neonate is a result of increased hemolysis and bilirubin production, limited hepatic conjugation, and increased enterohepatic circulation of bilirubin. Bilirubin is a metabolic end product of heme, a component of hemoglobin. In healthy individuals, approximately 80% of heme is produced during the breakdown of aged erythrocyte in the spleen. The remaining 20% accumulate during the red blood cell formation in the bone marrow, also termed as erythropoiesis. In neonates, the life cycle of fetal red blood cell is only about 70 to 90 days compared to 120 days in adults. This increased turnover leads to greater hemoglobin breakdown. There are some conditions that can exacerbate hemolysis like ABO or RH incompatibility, resulting in immune-mediated destruction of RBC, and hereditary disorder like G6PD deficiency or spherocytosis, which can increase hemolysis. Heme is absorbed initially by the macrophages of spleen, bone marrow, and liver, where it is further metabolized to become unconjugated bilirubin. In macrophage, the heme portion of hemoglobin is converted to biliverdin by the enzyme heme oxygenase, and biliverdin is then reduced to unconjugated bilirubin by biliverdin reductase. Unconjugated bilirubin is water soluble, so it is carried to the bloodstream by albumin until it is delivered to the liver. Once the unconjugated bilirubin is taken up by the liver hepatocyte, it is conjugated by the enzyme uridine diphosphate glucuronide transferase and then excreted by the hepatocyte into the gallbladder and then in the duodenum. Now, in case of newborn, the liver's ability to conjugate bilirubin is limited because of immaturity of the enzyme UDP glucuronide transferase, which is responsible for attaching glucuronic acid to bilirubin and making it water soluble. Normally, conjugated bilirubin is excreted into the intestine along with bile, where it is metabolized by the gut bacteria into urobilinogen. This urobilinogen is a colorless intermediate product, and 80% of this urobilinogen gets converted by the bacteria initially into stercobilinogen and finally into stercobilin, which gives feces its characteristic brown color. And the remaining 20% of urobilinogen is reabsorbed from the intestine and transported via the blood to the liver. Since urobilinogen is water soluble, it can be re-excreted in bile. This creates a circulatory process known as enterohepatic circulation. Reabsorbed urobilinogen can also be excreted by the kidneys. In kidney, non-enzymatic oxidation of urobilinogen leads to its conversion to urobilin, which is responsible for the yellow characteristic color of urine. Now, in neonates, the underdeveloped gut microbiome and slow gastrointestinal motility can lead to increased deconjugation of bilirubin by the enzyme beta-glucuronidase, leading to increased reabsorption of unconjugated bilirubin from the gut into the bloodstream, further contributing to the hyperbilirubinemia. These factors result in rise in unconjugated bilirubin level, which are lipid soluble and can deposit in tissue, leading to jaundice that will create yellowish discoloration of skin, sclera and mucous membrane. This typically appears first on the face and then progresses downward as bilirubin level rises. Besides the yellowish discoloration of the skin and sclera, other symptoms include dark-colored urine, which is a stain in the diaper, clay-colored stools, irritability, high-pitched crying, baby not feeding properly or not gaining weight, excessive drowsiness or sleepiness, and fever in case of sepsis. Diagnosis involves visual examination and measuring serum bilirubin level. Transcutaneous bilirubinometry or modified Cronber's scale is a non-invasive method often used for screening. It estimates the severity of neonatal jaundice by visually assessing the extent of yellow discoloration on the newborn's skin. It divides the body into 5 zones, with jaundice progressing from the head downward as bilirubin level increases. If it is left untreated, it can lead to cornectasis, a serious condition where high level of unconjugated bilirubin crosses the blood-brain barrier, causing permanent neurological damage such as hearing loss, motor disorder, or developmental delays, or even death if it is left untreated. Now, let us talk about its treatment approaches. Treatment depends on the severity of hyperbilirubinemia. Mild cases resolve on their own, but more severe cases may require interventions such as phototherapy or exchange transfusion. In phototherapy, blue light converts unconjugated bilirubin into water-soluble form, which can be easily excreted. And in critical cases, exchange transfusion may be necessary to replace the baby's blood to prevent complications. Early breastfeeding and hydration can help in increasing gut motility and reducing enterohepatic circulation of bilirubin. To summarize the video, neonatal hyperbilirubinemia is a manageable condition when detected early, and understanding its pathology, physiology can help healthcare providers and parents to act promptly and ensure a healthy start of every newborn. Thank you for watching my video.